we're going to see the nursing care aspects of pain and pain management, and it'll be purely from the nursing care aspect. So I don't know how many are nurses and how many are not, but I'm sure we all will get an understanding of what nurses are facing, and then how do we manage pain in our clinical situations. And I'm so glad and happy to introduce Mrs. Shakila Murali. I'm really privileged that she is taking this session on pain. Mrs. Shakila has been a charge nurse for the past many years. Especially she's been in palliative care for the past 18 years. And she started her career as a staff nurse in the surgical nursing department, and she went on to become a charge nurse in the radiation oncology department and the ward. And from there she took up with her interest in palliative care. She became the palliative care nurse, and she is the charge nurse in the palliative care team. She has, to her credit, many achievements. One is her nurse leadership bursary program that she did in London in the year 2006. It was a 2-month course, and she was selected for that, and she did that, and she has a certificate from the IAPC for the course in palliative care. She finished this in the year 2008, and she also has a training on end-of-life nursing, and she has been part of the consortium, End-of-Life Nursing Education Consortium, as a faculty member, and she has trained many nurses with the palliative care team in different parts of India. In 2013, she was also very much part of creating a core curriculum for UG medical and nursing students on palliative care, and that has come up very well and is being used. This was this initiative that was done in Trivandrum, and she has contributed so much to that. She has some papers that she has published for her credit. Overall, I know her personally as a student and as staff, and she has been a wonderful nurse and very passionate about those who are in need, especially at the end of life, who are in much pain. Maybe many have just abandoned, but she is one person who still feels that something can be done. As a person, she's a kind-hearted and a loving person, and I'm glad that she's going to share about the care of patients with pain, a nursing care perspective. I hand over the session to Shakila, and I hope at the end of the session we'll have some discussion, and if there are some questions, she will definitely address those. Over to Shakila.
Good afternoon, everyone. Thank you, ma'am, for the warm introduction. I would like to thank the organizers, the Chaplaincy department, giving the opportunity and choosing this topic also. Such a wonderful output they put in. I thank. And also I thank our nursing student choosing me to present here in this symposium. My topic is caring for patients with pain, a nursing perspective. As an introduction, access to adequate pain relief is a fundamental human right. Everyone needs a pain relief who are in need. Assessing and managing pain are essential component of nursing practice. It is a complex phenomenon that is uniquely subjective. Pain traverses all clinical setting and age spectrum. Either it is in the hospital, outpatient clinic, or in the community, or even at our home. We all in one time as a carer, like your family members are really suffering pain, we will be taking care, or we would have been taken care of that person. So one has, at least one time we would have been a carer for those persons. So how it is important to take care of those people in pain. Not only the physical pain I'm talking, the four aspects of pain I'm talking about: physical, mental, social and spiritual pain. And also, starting from a newborn child, even newborn child can experience pain. So a nurse who's there present in the hospital I'm talking, even the labor room, at the time of birth, even from there till the end of the dying patient, even after death, how dignity, give dignity to the person even after death while giving their care, without hurting a person. So that is a crucial role for a nurse when they care a person. I put these two definitions. McCaffrey defines pain as whatever the experiencing person say it is, and whenever he say it does. And the other definitions is also can be said. The American society goes further, stating that is not the responsibility of the clients to prove they are in pain. It is the nurse's responsibility to accept the client's report of pain. This is very important. So, pain is very subjective. Whether it's a small person or big person, single poke or multiple poke, pain is a subjective, what they feel. Even a group discussion, a person said, we cannot understand the pain. We can say, I can understand. It is difficult to understand somebody because it's a subjective. But we help them to go through and provide comfort in that, or what we could help in that suffering. That is our role. In a simple way, if I put it, it's acute, mediated by A fiber, and it's a protective and short-lived. Example, post-operative pain, when small or simple fracture. It will be there for a short while, and once it's treated, it goes off. Chronic pain is mediated by C fiber, and it can lead to destructive, permanent neural damage. It can be seen in genetic changes also, and it can impact on the social, psychological, and spiritual. Factors influencing pain threshold. Each person has different threshold. Example, when I was posted, like that reminds me often, when I was posted as a student in a labor room, only illiterate shouts, educated doesn't shout. That kind of people, why are you screaming like that? So, that kind of attitude what I had, which was wrong actually. Because people from village, they scream like anything. That I understood as a student. As I go through my experience, it is not true. It depends on each person's threshold. It is lowered by, and this is threshold is lowered by anxiety, social isolation, insomnia, fatigue, misinterpretation, and resolved pain. Everybody would have undergone some pain in your life. Either small pain or big pain or multiple pain or single pain, or any headache, small headache. How it impacts our daily routine. 1 day of pain or 1 hour after paracetamol it goes off some pain. But the impact, how much we give to our daily routine is different. It is raised by reassurance, companionship, sleep, rest, understanding, and good symptom management. So here the care is very important. So when we talk about pain, as I said, it is the 4 aspects of the well-being. When I studied nursing, what is health? The 4 component comes, that is, anyone is disturbed, well-being is disturbed. That's my first definition I studied in nursing, health definition. So same way the pain also, It is anyone is like a psychological, social, spiritual, whatever is disturbed, the pain. This concept brought by Dr. Dame Cicely Saunders, who is the founder of modern hospice. She brought. She was a social worker, she was a doctor and nurse. She was three aspects she undergone, and this brought up this. So when you talk about physical comorbid factors like a diabetic neuropathy can cause pain caused by surgery or like radiotherapy, some injuries will be there. Caused by some procedures like biopsies can cause and caused by illness. There are social loss of role and social status. If how long they can take leave from the work or the productivity of the financial productivity of the person goes down, loss of job and worries about the future. Not only him, his family. And anxiety, fear of suffering as a medical person. If small headache, small abdominal pain, whether I'll correlate to cancer. Oh, this pain could have been a cancer. Oh, can I go for an investigation like that? So, fear of suffering, because I know big disease means what are the suffering. We have seen our patient. That experience will also interpret those. Fear of suffering and depression. Starting from sadness to depression and goes for a suicidal ideation. And spiritual, anger with God, why me? What did I do? Loss of faith, finding purpose in life, fear of unknown, uncertainty. So as a nurse, when we encounter our patients or when we assess the patient, as a holistic, comprehensive assessment is needed in all aspects. So coming to the nursing assessment of pain, so we take pain history. If I'm going morning, if I go to the bedside or in the outpatient department, just I ask, how are you? That is open question I ask. Patient will start narrating from yesterday, if I've seen the patient from the time until I'm meeting, how was the night, what are the problem he encountered related pain, whether he slept, whether he has eaten or he shouted. These are the, just ask open question, how are you? That really helps. Or in case patient says the pain, when they start, we can ask, tell me about your pain. So the assessment is, the patient will narrate. You get a lot of cues when you take pain history. And then location, intensity of pain, severity of the pain, past and present experiences of the pain. What kind of experience? Could be a experience of bad experience or the good experience, how people have been supported, how he has been treated earlier, how well he has been treated, how he recovered. Those experiences will tell us. And physical examination, physiological response, and daily pain diary. So even our group discussion we were talking about diary will tell how much patient has undergone and what all the previous treatment he has undergone. This diary will tell us about that whole person. So in nursing, pain assessment, easy to remember, PQ, OPQRST, it's a mnemonic. O is like when did it begins, how long it has that duration, onset. P is a provoking or palliative. Provoking, what makes you worse? When we ask question, what makes you worse the pain is? Or like example, if I walk only, my pain worsen. If I lie down or sit down, doesn't. Or if I vomit, my pain relieves. These are the small clues we give. We get it from the patient when we ask such questions. And or as a palliative factor, what makes you better? Like if somebody massage me, that really comforts me. That what are the factors that really give comfort to the patient? Quality of pain. There are different quality of pain, like a pricking pain, or squeezing pain, or burning pain. That kind of characteristics of pain we ask. Then region where it is located, which person. Some people, see, I'll be pointing out one pain where he is. But there are other places also he will have pain. So there's a body chart, we point them or we tell them where all you have pain. So it starts from one place or goes to the other place. It's a radiating pain. So it is only localized pain. So this kind of assessment really help in management and severity of pain, how severe it is. I'll be showing a scale, how we assess the time and treatment. When did the symptom first begin? Is it 3 months back or 1 year back, or was it worsened same when it started worsening? This kind of, what are the medication he or what are the treatment he had undergone earlier? So because our institution is a tertiary center, they would have gone, we have a lot of people from Northeast and they would have gone many places and come here as a tertiary center. So what are the treatment earlier they received? And understanding and impact of pain. What does patient understand? Not my understanding by looking. What patient understood about the pain and the impact of pain and that. So easy to remember this OPQ RST mnemonics in pain assessment. That's what we follow. So nursing assessment is a crucial role for the nurses. Unless our assessment is properly done, the management depends on that assessment. So pain relief depends on the assessment. So as a nurse, we have to do it in a correct way. I put the slide here, scale here. What we use, every ward has this scale. So this is called numeric pain rating scale. 0 is no pain. 1 is the minimal pain, the lowest pain one, and 2, 3. These will like a mild pain. 4, 5, 6 a moderate pain. Kind of descriptive also we can. 7, 8, 9 is a severe. 10 is an uncontrolled pain, crucial pain, uncontrolled pain. It's a maximum worst pain. 10. So this is a scale what we use for the patients in the wards, in the OPDs, also some of the OPDs. There are other tools available, visual analog scale. We ask the patient. Like example, if I show this patient, I'm illiterate, I cannot answer. When they are in pain, they find very difficult to incorporate what we ask for it. So because it's a subjective, we ask the patient. Sometimes the relative jump and say 8, 9. We don't want the relative perception in the pain. We want the person what he felt the pain is, the intensity of the pain is. So we'll ask the patient to point out which number. So we cannot guess and put and record also. By looking at the face or looking at the suffering, patient may say, the relative will come and tell us number 7, 8. But patient, when we correctly explain this, they say 3 and 4 also. So this person has pain has to report. And also, people who cannot understand, like percentage we can ask, 10%, 20%, 50%. Even further, if they don't understand, some people know I am illiterate, totally I don't know anything, 1, 2, 3 also. Everybody handles money, isn't it? Every human handles money. So we ask 10 rupees, 20 rupees, 30 rupees, like 100 rupees out of 100 rupees, how many rupees you have paid? 50 rupees means half. Like that we explain them to understand, to tell about what the severity of pain is. Next is a visual analog scale. By looking at them, they point out where the pain is. There are other tools for children also they use. By looking at the faces, we can put some people, children cannot express, verbalize. So those, by looking at the faces, we can rate other tools. Coming to the treatment management part, treat the underlying cause. So there are chemotherapies, hormonal therapies, radiotherapies and surgery will relieve pain. So we have to treat the underlying cause for pain. Once we identify the cause for pain, then pharmacological management, the drug. Second is explain and listen to the patient what the treatment we are going to offer. Then non-pharmacological management and interventions. These are the management strategy. In drug management, there is a WHO ladder. Universally it's followed. Like step 1, step 2, step 3, newer version 4 also, but this is a basic thing what we have. Like when we find out person has a pain, mild pain, and non-opioids and adjuvant. I'm not going to go through the drug names and all. Mainly I'm concentrating on the nursing things. The step 2 is opioid for mild to moderate pain. It's a weak opioid, non-opioid and adjuvant. So plus in step plus 1 also will be added. In step 3, strong opioid for severe pain plus step 1 non-opioid and adjuvant along with the non-pharmacological plus or minus will be added into the every aspect where it is applicable non-pharmacological therapy. Otherwise some people say it's a complementary therapy also is used. This is a WHO approach by the ladder, by step. The ladder what I showed, WHO ladder, by the clock. So many places we want the relief for 24 hours, not only day and night, like a once a day tablet, twice a day. We know unless we understand the action and the duration of action, it is better to follow 24 hours pain relief for the patient. Some of the drugs only once they give or twice they give. From 9 a.m. to 9 p.m. 12 hours, patient will be in pain. If at all daytime coverage alone is there. So by the mouth is why it is so simple. By the mouth individually without depending on others, patient can have it. So as simple as by the mouth and by the individual, it is pain is a unique. Each unique person how they experience is unique. So by the individual, it is we have to assess and with attention to details are how the treatment and how he perceives. These are the what are the treatment he's other than drug management. What are the things needed? That also attention to detail we have to do that. These are the different routes, not only injectable and oral, there are different routes available, there are different routes drugs available for the drug management. And coming to the non-pharmacological pain management, cognitive and behavioral interventions, physical or sensory interventions, there are 2. Physiological preparation and education of the psychological and preparation and education of the patient is very important. How we talk to them and listen to them, how we are going to approach in pain relief, that is very important. Distraction, there are other modalities, distraction, movies, games, TVs, different apps, even mobiles, different apps are available, toys and with lights and sounds, virtual reality, then relaxation techniques, breathing techniques, meditation. There are foot massage to relax. There are studies done on foot massage, really helps. Simple back rub really helps, but on the inflamed area we should not rub that kind of thing. We have to be really sensible. And music therapy, guided imagery and coaching towards what are we going to teach and what is next, and conversation and therapeutic languages or behavioral therapies. There are supportive devices available, like small things like a neck collar, extra pillows applying to that, then slings, walker, spine support, where all it is available. Where are the resources? So just telling and going is not adequate. When as a nurse, if I say like a person who I feel as a nurse, if I feel a sling will be helpful for the patient, I won't tell our physician to do this. I feel like that. So they know then they think it really okay, I'll do it. And where it is available, giving prescription doesn't, and we teach them and how to apply and what are the effects of applying. It should not in the wrong. Which are the wrong ways not to apply for that, and correct way to apply. These are the education needed for those patients. Just giving walker, how to put legs unaffected leg first, then affected leg. Otherwise, the patient when they walk also first they put the painful leg first. where a lot of weight will be put and reverse it. So these are the demonstration needed for those patients. Nurses' role in pain management, nursing diagnosis could be acute pain or chronic pain, actual pain, self-care deficit, anxiety, ineffective coping, fatigue, impact physical mobility. These are the After setting the nursing diagnosis, we plan for the goal and outcomes of those patients, setting priorities, which one we have to set priorities, and continuity of care, even after going home, what they're supposed to do it. Then implementation of those cares and evaluation, because whatever we do, it is we have to evaluate and reassess. And nurse also will be patient advocacy, self-awareness, knowledge of pain and pain assessment, and knowledge of standards of care for pain management enhances the nurse's ability to advocate for patient and assure effective pain management. Like example, if a person could be a social pain or could be a psychological pain, but during rounds they may not recognize as a nurse, because from the day of admission as enters in the ward till the discharge, nurse is there all 24 hours. So she would have encountered the psychological or social, spiritual pain. We will be advocating to the team members and other people whom to approach for those. Because as a nurse, in some aspect I may not competent enough to do that. So where to refer, whom to refer, that I'll be a patient voice. I'll be talking for the patient to the other team members. That's have a great role on that. And also, when patient relief is inadequate or undertreated, I'll be voicing out for the patient unless I have a knowledge in the depth of the patient and the family, as well as and for the knowledge of the pain and the drugs. Because example, many times I've encountered, like some of the drugs, I know the side effects, what we learn in nursing, like example, tramadol. That reduces the threshold. So by mistake, anybody writes the drug, already patient would have had seizures disorder. I can very well go and tell, this is the drug can cause seizures. So patient, because the drug is going to cause the threshold, going to reduce the seizure threshold. So immediately, doctor could treat where I'm working, they know the knowledge and they recognize my knowledge, they value that. So a nurse who doesn't show the capability or the knowledge acquired, it's not easy to talk for the patient. So unless we have the knowledge and experience, we will be voicing out for the patient. Some patients are undertreated, that also. So why can't we do? We'll have a discussion. Why can't we try in this way? I felt it is better. So these are the aspects we can advocate for the patient. Nurses take a major role in advocating for the patient and the family, even in the hospital, home, wherever even the OPD. Then the major role is patient and the family education is major role. How and when to request interventions for comfort and symptom relief. Importance of preemptive pain management. And explanation of the drug chart, like dose. I will be explaining to the dose, time, duration, action, and expected side effects. And even small action, take the tablet, put it in the same cover, that really relieves. Because our patients and family tendency, they take one like painkiller tablet will be put into the laxatives, that's constipation problem. So patient will be taking the constipation, to relieve the constipation, that tablet instead of pain tablets. So make sure it is the right drug is put into the right cover, and it is being explained, tell them to. That is very important to maintain the compliance. Supervise drug administration, bring all medications on each visit. We encourage them to bring all the medication what they are taking and bring it back. So that time only we know how patient is taking correct medication or correct dose, or whether because our culture many patients say yellow color tablet, mancha color, sagam color, white color, could be anything. So the right drug, what patient, we cannot assume what they're taking. Is it green color means I cannot, oh green color, this is a tablet. We cannot. Different companies make different colors, different. So make sure patient brings all the drugs and we explain them and what are the drugs for what. Addresses pain management whenever warranted by the patient condition. Provide the name and telephone number of the individual to contact in case of any problems such as excessive discomfort, where to go, whether to contact, the telephone numbers. Mostly we give the office numbers. The physician note may also include explanatory details for patients' awareness regarding pain causes and management. So these are the points we include in educating the patient and the families, and also we tell them how to keep the drug, like children away from children, and if patient is experienced earlier a suicidal attempt or anything, so we tell them to keep away the family, to instruct and whom to give the medicine, not to keep next to the patient. They can be kept in a higher way, and the family members will be counting the drug after giving. That is very important, because they be thinking that okay, taking and giving is their responsibility. So how much is left over us? When they come like educated, we have in India high educated, the poorest of the poor. How it's a simple way, the colors, like a morning sunrise to remember, morning yellow, and night will be the dim yellow, blue. Pink will be the liked by everybody. So whenever needed, those drugs are put, at least 3 doses, they don't miss it. So if at all we explain, and many times they find very difficult to understand, and complaints will be mostly it's difficult. There are complicated pains also. So the small strategies we give them and to help them to manage and complaints with that. We have standard of policies, nursing service policies and pain management, including pain assessment, management and documentation. Pain assessment is completed within the first 2 hours of admission and documented the nursing assessment and admission record. Allergic to any patient pain medication is documented in the nursing assessment and admission record. All the patients are assessed at least once during each shift for pain using the appropriate pain assessment scale, and the score and the intervention documented in the patient monitoring record. Pain score and interventions are interpreted. When the pain score is over 3, inform the physician. There are patients with pain are reassessed. 4 hours of pain assessment. Person receiving specific analysis like a PCA, patient control in post-operative, patient control analgesia. These are the infusions, when to monitor, and every 30 minutes or every 4 hours, well defined in the policy. So the standard of care is maintained. And pain management is a policy stated pain management is done through the pharmacological and non-pharmacological interventions. And pain management options are discussed with the patient and the family and the caregiver, so they continue the care at home. Non-pharmacological and pharmacological interventions are initiated to elevate pain immediately following the assessment. Doctor is notified when any type of prescribed pain management regime is not effective or in relieving pain or not available. Some of the drugs won't be available in the pharmacy. In case we immediately inform and change the prescription. Changes are made in the treatment, and patient is re-evaluated within the appropriate time framework until pain is tolerable. and reassessment is done, depends on the route, depends on the treatment, either 30 to 40 minutes, 45 minutes or 15 to 20 minutes. And cardiac pain is every 5 minutes is reassessed. And documentation necessary whenever the assessment and management is documented and it's monitored in the record. Then there are common myths are contributing to ineffective pain management. Pain medication will cause substance abuse, addiction, respiratory depression, hasten death. Pain should be treated, not prevented.
It is a myth. People in pain always report their pain to their healthcare providers. People are in pain demonstrate and shows that they have pain. Pain can be seen in patient behavior. The level of pain is often exaggerated by the patient. Some pain is good, so that patient symptoms are not masked. Newborn infants do have pain, as I said. It is expected that the elderly, especially frail elderly, always have some pain. Age after 60, yeah, knee pain it will be there. In chronic progressive illnesses, adequate pain relief is impossible. It is possible, pain relief is. There are certain extent and take-home points I want to tell. Listen to the patient, what he says, and believe what he says. Empathy and compassionate care, because our patient deserves high quality of care. So here I want to finish. Do not withhold good from those at whom it's due. It is in your power of act. The Proverbs say 3:27. And do not forget to do good, and to share with others such sacrifices God pleased. Hebrew 13:16. Once again, thank you.